This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. This morning we have Dr. Parashar from the Division of Cardiology. As all of you know, Susmita is an associate professor in the division. Susmita had a somewhat unusual career course in that she was originally a member of the general internal medicine faculty here and then returned to do additional training in cardiology and has been a member of the faculty for 3.5 years as a cardiologist. Did I get that right? And her major focus, she has two major areas of interest. One is women's cardiovascular health, and the other is in this evolving and new area of cardio-oncology, and it's the latter to which she's going to speak today. So, Susmita, welcome.
Thank you, Bob, for the introduction. So, this is a very interesting topic, and it's very evolving. In fact, ACC had a one-day intensive course on cardio-oncology just this past month. When I started working on this field about 3 years ago, it was brand new and there were very, very, very few people. And now I'm just so happy to see that it's growing and people are recognizing it. So yesterday when I was rounding, one of my interns asked, what are you going to speak on? And I said, cardio-oncology. And he said, what is that? And so I'm surprised that he's not here, but so hopefully by the end of our talk, I guess he wouldn't figure out even now. So we'll just go over that. I really am interested in presenting the last three. At the end of my talk, there are 3 cases that are just extremely interesting and intriguing, and I just wanted to see what do my colleagues think about that. So I'm just hoping to get to those cases by the end. So the objectives of my talk is to understand cardiac implications of cancer treatment with potential cardiac toxicity. I'll review subclinical markers of cardiotoxicity and summarize what are some of the guidelines that are recently being developed. So let's start with some questions. All of the following are risk factors for anthracycline-induced cardiomyopathy except receipt of dexrazoxane, age more than 60 or age less than 18, mediastinal radiation, black patients, dose more than 300 milligrams per meter square. So I don't have the response system, so just speak up. Except. Yes, I guess. Okay, good. So the answer is receipt of dexrazoxane. Actually, it's a cardioprotective agent. It inhibits the binding of anthracycline to reactive oxygen species. All of the following statement is correct regarding trastuzumab Herceptin-induced cardiomyopathy except differs from anthracycline-induced cardiomyopathy in that it is not dose-dependent, does not increase susceptibility to anthracycline cardiotoxicity. Heart failure improves in 75% of patients with ACE inhibitor and beta blockers, partially reversible upon stopping treatment. I heard D. I'm not sure if B. Okay, so whoever said B was correct. So it does not. That's wrong. It actually, I'll show you data that it increases susceptibility when given with anthracycline. So this is the easy one. Everybody should be able to get it. Post-radiation cardiomyopathy can present as acute myocarditis, chronic diffuse myocardial fibrosis, restrictive cardiomyopathy, all of the above. All of the above, yes. Good test-taking strategy. So overview. I'll go over cardiac implication of the following cancer drug. There are a lot of drugs, but I just have enough time for these 4. Anthracycline, trastuzumab, anti-VEGF therapy, radiation. We'll go over can cardiotoxicity be prevented. We'll go over some of the guidelines. I really want to talk about something very dear to my heart, Cardio-Oncology Partnership Program at Emory, and then get to the cases. So a lot of things to do. So I want to start, the only reason we're talking about this topic is because cancer is a success story. We have survivors, and that's why we're worried about the side effects of medications. So in 2012, more than 13 million cancer survivors were there in the US and 2.5 million breast cancer survivors. So if you look at over the years, in both sexes, the rate of mortality has decreased over time for both men and women. If you look at this graph, it's cancer death rates among women. You can see that the breast cancer mortality has tremendously decreased from the year 1990s. Hodgkin's lymphoma is a huge success story, as you can see here. In 1970s, when anthracyclines were started, the mortality rate dropped pretty dramatically. What is interesting, though, is that after 10 years, so A is cardiovascular death rates and B is death rates due to Hodgkin's lymphoma. And you can see here that the death rates due to Hodgkin's lymphoma remain pretty stable over the years. But look what happens over the years. The cardiovascular mortality rates increase, and over by 15 to 20 years, more people die of cardiovascular deaths than Hodgkin's lymphoma. So how does cancer treatment affect cardiovascular system? Remember that people with cancer also have traditional risk factors of coronary artery disease. Some of the cancer treatments accelerate atherosclerosis. There could be direct myocardial toxicity. There's impact of cardiovascular disease during cancer treatment, which we'll go to when we talk about cases. There is valvular disease, pericardial disease, endothelial dysfunction, and some of the treatments are pro-arrhythmogenic. So let's talk about the cardiac implications of these drugs. So before we start, I want to present a real case. This is a 42-year-old African-American woman with breast cancer diagnosed in January of 2012. She does not have any risk factors except obesity. She completed treatment with adriamycin, 240 milligrams per meter square with cyclophosphamide, followed by paclitaxel. In December 2013, she was admitted with fever and dyspnea. She was ruled out for PE. She was treated with UTI. In January 2014, she was admitted with dyspnea again. This is her echo. It's stuttering. I apologize for that. But you can see the EF is not more than about 25-30%. There's a lot of mitral regurgitation. This is the short axis view. Again, the EF is dramatically low. So this is a typical case of anthracycline cardiotoxicity. It is a commonest cardiotoxicity. It's dose-dependent progressive decline in LVEF, often resulting in heart failure. There can be two kinds, an early onset, which is less than 1 year, and late onset, more than 1 year. Early cardiotoxicity, Black patients are at especially higher risk. Late cardiotoxicity is associated with fibrosis and has insidious onset of subclinically progressive disease. It is extremely common. It's not a rare disease. Cardiotoxicity due to anthracyclines is seen in 50% of all survivors by asymptomatic echocardiographic features. More than 50% of patients have cardiac dysfunction 10 to 20 years after anthracyclines, and 5% have overt heart failure. It is dose-related. So as you can see here, about 1 to 5% of patients get cardiotoxicity at the dose of 550 milligrams per meter square. And at 1 gram per meter square, half of them get cardiac dysfunction. So there may be no safe dose of anthracyclines. What is very sad is that it is irreversible. What happens when people get cardiotoxicity due to anthracyclines? There is 6-fold increased risk of subclinical cardiotoxicity, 5-fold increased risk of clinical cardiotoxicity, and these patients have 5-fold increased risk of cardiac death. And even when these patients are asymptomatic, it really limits the therapeutic cancer options for these patients. This is a graph showing the survival rate for patients with different kinds of cardiotoxicity. You can see peripartum is here, idiopathic. And cardiomyopathy due to doxorubicin therapy is much worse prognosis compared to even the other kinds of cardiomyopathy. So doxorubicin cardiomyopathy 3.5 times as risk of death compared to idiopathic cardiomyopathy. So these patients get really sick and die pretty soon, have high rate of mortality. This is a study which was published in Journal of National Cancer Institute. Risk of heart failure is highest after anthracycline and trastuzumab treatment. So for breast cancer patients, some of the patients get both trastuzumab and anthracyclines. You can see here that the solid line is anthracycline cardiomyopathy incidence. The dotted line here is trastuzumab, and when the patients get both, the incidence of heart failure is much higher. So if you look at the rates here, anthracycline is on the top row, and if they get both, the rate is very much increased for heart failure in these patients. This is the study that was published in, the same study, but this was risk stratified and published in New England Journal of Medicine. So this was stratified by age, and you can see here in patients who are older than more than 75 years, if they get both trastuzumab and anthracyclines, the incidence of heart failure is very, very high. And because the graph is not that clear, I've given you the numbers here. You can see by 5 years, about 40% of patients get heart failure. This is when the patients are younger, 65 to 74 years. Again, here you can see by 5 years, about 36% of the patients who get both anthracycline and trastuzumab have much higher incidence of heart failure. I'm presenting the data here again just because it is extremely important that when people get both trastuzumab and anthracycline, 28% of patients get ventricular dysfunction and 19% of patients get symptomatic heart failure. So doxorubicin-induced heart failure increases with cumulative dose of doxorubicin. As you can see here, this is the total dose of adriamycin or doxorubicin on the x-axis, and probability of heart failure in y. And you can see here as the dose of doxorubicin increases, the probability of having heart failure increases tremendously. So how do anthracyclines work? For those interested in basic science, anthracyclines are natural products derived from Streptomyces species. It's relatively hydrophobic. It basically inhibits the DNA polymerases and DNA fragmentation and generates oxygen-free radicals, which may be involved in anti-tumor effects, but also unfortunately causes cardiotoxicity. So anthracycline-mediated cardiotoxicity generates reactive oxygen and nitrogen species, causes abnormal calcium and sodium influx, leading to metabolic ischemia, which may lead to diastolic dysfunction and ischemia. And this is where the dexrazoxane works, as I just was mentioning to you. When you look at it under electron microscope, doxorubicin causes microfibrillar disarray. So it has loss. This is a normal myocardial cell, and here you can see there's a disarray of myofibrils. There's dilatation and of sarcoplasmic reticulum with swelling of the mitochondria and vacuolization, as you can see here and here. So what are some of the risk factors? Pre-existing hypertension, coronary heart disease, diabetes, LV dysfunction, young age or older age more than 60, African American race, as we just talked about, dose more than 300 milligrams per meter square, combination chemo, and mediastinal or left chest radiation. So now let's talk about HER2-targeted therapy-associated cardiotoxicity. So I'll start with a case again. This is a case of a lady who's 56-year-old, who has HER2 positive breast cancer, no cardiac risk factors. She had lumpectomy. She was scheduled to receive anthracycline, and then she received trastuzumab and paclitaxel for a year. Her baseline EF before she started anthracycline was 60%. After anthracycline, it was 55%. And at routine 3-month echo after she got trastuzumab, the EF is 45%. No clinical evidence of heart failure. So the question is, should the patient receive trastuzumab or not? That's where I was consulted, and what other treatment should the patient get. So we'll go over that, and hopefully by the end of it, you'll be able to answer this question. So what is HER2 receptor? This is a totally different language for me as well, so I had to learn it all over again. So HER2 receptors are expressed in about 25% of breast cancer patients. Prior to HER2 therapies, HER2 breast cancer had very poor prognosis. Trastuzumab improved survival in both adjuvant and metastatic HER2 breast cancer. Mortality is reduced by 1/3, but the risk of heart toxicity is 5 times more. 17% of patients have to stop therapy due to cardiac complications. So here you can see the mechanism of how trastuzumab works. It basically binds the HER2 receptors and prevents the activation of NK cells. So the mechanism of trastuzumab is pretty much, it's quite different from how anthracycline works. Anthracyclines damage myocytes, causes apoptosis, some might be repaired. Trastuzumab actually interferes with cell repair, and I'll tell you why this is so important in the next few slides. As I just showed you, if patients receive both anthracycline and trastuzumab, their risk of heart failure is much, much higher. So these are the key points, the differences between doxorubicin and trastuzumab. Very important to understand this. The doxorubicin causes cellular death. Damage starts with the first administration. Trastuzumab causes cellular dysfunction. There is biopsy changes for anthracyclines. There's no typical biopsy changes. Doxorubicin is dose-related. Trastuzumab is not dose-related. It causes permanent damage in the anthracyclines people, and trastuzumab is potentially reversible, which is a good thing. These patients have good prognosis. This is bad prognosis if you receive anthracycline. Some of the risk factors are, as we just talked about. If patients get anthracyclines prior to getting trastuzumab, they have much worse prognosis. So, as we just learned about cardiotoxicity, the important part is to understand what is the benefit versus risk in these patients. So the important part to understand is for trastuzumab, is significant reversibility of LV dysfunction when it comes to cardiac toxicity. So in this particular study, as you can see, the LVEF was about normal prior to trastuzumab therapy. After trastuzumab, the LVEF was decreased. But following standard therapy of heart failure therapy, the EF actually increases. And importantly, if you then challenge them with Herceptin or trastuzumab, the EF does not decrease very much. So this was very important. So now I'm going to ask you the same case. Remember that her EF was 60% baseline, 55% after anthracycline, and now 45% after she got trastuzumab. So what should we do? Should the patient get trastuzumab or not? So the packet insert for Herceptin states that if there is an absolute decrease in LVEF of more than 16% from pre-treatment values, or LVEF of less than 50% and 10% absolute decrease, they should have trastuzumab held until repeated echo confirms LVEF recovery. And I cannot tell you how stressful this is, because you are making a decision as a cardiologist about whether to give this patient a life-saving therapy or not based on your the ejection fraction. So you have to be really, really sure you have patient and the entire family sitting in the room and the oncologist on the phone. So it's very stressful. So for this patient, baseline EF is 60%, after anthracycline 55, and now 45. So who is going to hold trastuzumab and who's going to give it? Should we hold it or give it? So that's correct. So we held, this is one of the guidelines that we recently worked on last year. It's in print. It's part of the International Cardio-Oncology Society that Emory and I am part of, and I'm going to show you this later. But this is something that we just wrote. It's pretty much similar to what FDA recommends that if there is 10 absolute points of decrease to below 50% or decrease to less than 50%, you have to hold trastuzumab, repeat echo in 3 to 6 weeks, and if LVEF has normalized, then they can resume Herceptin. And in the meantime, we recommended that ACE inhibitor, ARB, and beta blocker should be started. So that's what we did for this patient, and actually her EF came up, and she received Herceptin again. So very few words about anti-VEGF therapy. So these are some of the drugs that you may come across: sorafenib, sunitinib, and others. These are used for multiple cancer treatment. The main side effect I want you to remember is hypertension. It is caused, the side effect is in 15 to 60% of patients. I thought this was interesting, so I put it here. This is in Lancet. When they did the study, they said they found no evidence of systematic mean decrease in LVEF. What is interesting is in the prescribing by Pfizer guidelines, it says in double-blind treatment phase of these patients, 3% of patients had LVEF placebo and 11% had decrease in LVEF when they received Sutent. So I'm surprised that there's a discrepancy in the two studies. So this is a radiation therapy case. Again, a patient, actually I think Dr. Douglas I already gave you the information, but he got a couple of stents. But this is 56-year-old male, no cardiac risk factors except 10-pack a year smoking. He quit smoking 10 years ago. He was diagnosed with Hodgkin's lymphoma 10 years ago. He was treated with CHOP and radiation therapy, came to cardiology clinic with chest pain, underwent nuclear stress test. This is the image for the nuclear stress test. As you can see here, these are the rest images and stress images. The anteroseptal wall is quite ischemic. About 25% of the LV area was involved. So this patient underwent cardiac cath, and this is his film here. As you can see, there's a bifurcation lesion here, and there's one here as well. So the radiation for breast cancer increases ischemic heart disease. The risk for ischemic heart disease is proportionate to mean dose of radiation to the heart. It begins with the first 5 years of radiation and continues for 20 years afterwards. The pre-existing cardiac risk factors increase risk from radiation. It has atypical location of CAD, as we just saw. It's mainly an osteal disease, mainly in bifurcation areas. As you can see here in the slide, as the mean dose of radiation to the heart increases, there's a risk of rate of CAD increases as well. This is just a slide of the coronary calcium here. As you can see here, there's a lot of coronary calcification in the LAD and the circ area in patients who receive radiation therapy. There are other issues with radiation therapy as well, including pericarditis, constrictive pericarditis, which is much decreased after we have used newer shielding. There is valvular heart disease, conduction system disease, as well as vascular disease, as well as arrhythmia. This is one of the pictures for radiation-induced valvular heart disease. As you can see here, there's thickening of the mitral valve. There's thickening of the aortic valve as well, with aortic stenosis, as well as a lot of AI. So the important part is we've realized, well, are we doomed forever? Can we prevent cardiotoxicity? That's the main question we have at this time. So I want to go over what are some of the strategies which we have used. The treatment modification, we can decrease the peak dose by increasing the infusion times, the slow infusion. The drug-free interval between anthracycline and trastuzumab, if you keep some interval, then the toxicity is less. Some analogs such as epirubicin and idarubicin have less cardiotoxicity, and then cardioprotective agent such as dexrazoxane, as we just talked about. We are now shielding better when we use radiation compared to older times. Some of the other predictors of cardiotoxicity that have been used in other centers, as well as Europe, are troponin and novel echocardiographic markers. So we did a study here called the NOVEL study, which we just completed, where we enrolled about 50 patients who were undergoing treatment for lymphoma. And we looked at, actually Sharon helped us, she's here, about with longitudinal strain in these patients. And this is one of the slides that shows a decrease in the peak systolic strain in patients who are undergoing cardiomyopathy, who are undergoing, treatment for breast cancer or lymphoma with anthracyclines. This is one of the study which was published in 2012. You can, in this study, they looked at patients from baseline to 15 months who were receiving anthracyclines and trastuzumab. They administered questionnaires at 3 months, 6 months, 9 months, 12 months, 15 months, and did biomarkers as well as echocardiography. They found that this is a decrease in LVEF over time, that the longitudinal strain actually precedes the LVEF decrease. When we look at troponin, the troponin is actually increases over time, and it corresponds to decrease in LVEF and decrease in LV strain. In other prior studies too, troponin I predicted trastuzumab-induced cardiotoxicity and lack of LVEF recovery. In multivariable analysis in this particular study, troponin I was the only independent predictor of LVEF decrease. So can cardiotoxicity be prevented by using ACE inhibitors or beta blockers? This is one of the very important studies by Dr. Cardinali, who is in Milan, Italy, and published in Circulation. You can see here in the controls, 43% of the patients who got anthracyclines had LV dysfunction. In ACE inhibitor group, interestingly, only 0%, none of the patients had cardiac dysfunction. Giving patients ACE inhibitors also decreases cardiac events. As you can see here, 52% of the patients had all these cardiac events, any of these cardiac events, at 6 months compared to 2% of the patients who got ACE inhibitors. So it seems like if we give patients ACE inhibitors prior to their getting anthracycline, it may be cardioprotective. I'm going to skip over that. Now the question is, when do we actually start ACE inhibitors? Should we start it before patients get anthracyclines, during? We don't know. So this was one of the study that was done by Dr. Cardinali. She basically reported that LVEF recovery is most critical when heart failure treatment was started within 6 months of anthracycline. So you can see here, these are the patients who responded, and these by giving ACE inhibitors for LVEF recovery, 64% of the patients did not have decrease in LVEF if the ACE inhibitor was started within 1 to 2 months. And you can see here, after 6 months, very few people responded to ACE inhibitors. So it's important to get these drugs on board as early as possible. So we recommended, based on these data, that in patients with normal EF, plan for therapy with known cardiotoxicity. We use the word considered. Prophylactic use of ACE inhibitor or beta blockers may be considered. We could not say should, because there was just 1 or 2 clinical trial. What is important is different centers have different guidelines. There's no particular specific standardized guidelines for patients for us to do surveillance or monitoring of these patients. So we formed an International Cardio-Oncology Society about 2 years ago. There are 150 countries, 150 people from different sites, as you can see here, also from different countries. Emory is part of the group. We recommended that cardiac imaging should be done in every patient, which should be a non-irradiating imaging like echocardiogram. During cancer treatment, if patients are receiving anthracyclines, they are asymptomatic, they have no biomarker or imaging abnormalities. Biomarker should be done at 3 to 6 weeks or prior to each cycle. And LV function should be measured at cumulative dose of 240 milligrams per meter square after each additional 100 milligrams meter square dose and at the end of therapy. During cancer treatment, like we just talked about, if EF is decreased more than 10 absolute points from baseline or less than 50%, or decreased to more than 40 but less than 50%, LVEF should be measured at every dose of anthracyclines, and these patients should receive ACE inhibitors and beta blockers. If their patients have cardiac dysfunction, this is an important number to remember. If the LVEF is less than 40%, we have to stop anthracyclines. For trastuzumab, the cardiac monitoring is recommended for every 3 months. As we just talked about, if there is a reason there's LV dysfunction, we have to stop trastuzumab and repeat in 4 weeks. This is important. I just saw a patient who had completed trastuzumab. The question was, how often should we check echoes? We have to check it every 6 months for about 2 years. For patients with trastuzumab, we've already gone over that. If there's decrease in EF, we have to hold the medication and check the LVEF. Longitudinal strain is also a new modality. What is important to remember is that life-saving chemotherapy should not be altered based on LV strain. So actually, there's a real case of a patient who had breast cancer. She was going to start chemo, but before she started chemo, she wanted to go to Hawaii. So she went there, and she got a call from one of the centers, Echo Lab, saying that her LV, from her oncologist, that her LV strain had reduced, so she could not receive chemo. She canceled her trip and came here only to find out that that's not the case. So actually, I don't even report LV strain in the report section summary. I and Sandra have discussed this in detail. We just put it in the where all our data are, just so that not to panic the oncologist. We have already talked about this trastuzumab. If there is less than 40% LVEF or heart failure, we stop it and repeat echo. In any patients who are at risk of atherosclerosis, we have to evaluate for CAD if there is any chemotherapy-related dysfunction. So we can't say that, well, it's all because of chemotherapy. We have to do our standard, judgment call and evaluate if this could be because of ischemia. What about survivors? This is important because this is a huge population that I'm seeing. Asymptomatic patients with normal cardiac function, biomarkers and cardiac imaging should be done at 1 to 5 years post-treatment, and every 5 years. If there is LV dysfunction, continue ACE inhibitors, beta blocker indefinitely, even if recovery of LVEF. If they received radiation therapy, ischemia and valvular evaluation should be done at 10 years and every 5 years, even if they are asymptomatic. We've already gone over that. So I want to present one of our studies that Olivia has put a lot of effort into. This we presented at the AHA Q-Core last year. We basically assessed the pattern of surveillance of LVEF and management of anthracycline-induced cardiomyopathy at Emory. So this was a retrospective analysis in non-Hodgkin's lymphoma patients who received anthracycline from 1992 to 2013. Cardiac function was evaluated by echo or MUGA. We defined anthracycline-induced cardiomyopathy as we just talked about, and we looked at quality of care based on AHA heart failure guidelines. It was quite shocking to us. Only 41% of patients had pre and post LVEF evaluation after receiving anthracyclines. 30% of the patients had only pre-anthracycline echoes, post-anthracycline only 4%, 25% of the patients did not have either one of them. This is the LV dysfunction rates among patients with pre and post LVEF evaluation. So the patients who got both the pre and post, we looked at what was their EF. 50% of the patients had moderate LV dysfunction and 12% had less than 35% EF. Only among these patients here, moderate and severe LV dysfunction, only 47% received ACE inhibitors, 40% beta blocker, and 40% received repeat LVEF evaluation. So we definitely can do better than this, and there's room for improvement. Thankfully, I felt so much better after looking at this particular study from Stanford and Denver. They had the similar rates, so it's not just us. We, in the entire US, it looks like we are kind of doing the same thing. So this is another abstract that we presented. So we looked at what predicts who are these people who are getting anthracycline-induced cardiomyopathy. We found that patients who had concomitant CAD, they were more likely to get cardiomyopathy. Smokers and diabetics, which is not surprising, they were more likely to get cardiomyopathy. I wanted to show you this slide because Olivia has put just an enormous amount of effort. She's one of our fellows, as you know, in putting up this paper together, and this we just submitted to BMJ. So what I wanted to show you is that the mortality rates among cardiomyopathy patients due to anthracyclines is much higher compared to patients who did not have cardiomyopathy. So I want to talk to you briefly about our Cardio-Oncology partnership program, and then I want to go through the cases where I really want your input. So this is after 3 years of hard work and trying to get collaborators through WinShip. Last year, they formally announced our program for WinShip collaboration addresses patient heart health. This is the first program of a kind in Georgia, and also one of the very few in the entire Southeast. This is our team. We have Adult Survivorship Program Director, Joan Giblin. Dr. Esias Villi is from, we established a young adult survivorship program, which I'll tell you about, medical oncology, radiation oncology, School of Nursing, as well as echocardiographers. Some of them have been really, really helpful, and cardiology fellows as well. It's one of the few in the United States. We want to address the cardiovascular side effects of cancer therapy, maximize cardiovascular outcomes for cancer survivors, as I just said, is first in Georgia. It's an interdisciplinary approach. We want to detect cardiotoxicity early. We want to institute cardioprotective agents early. We want to eliminate as much of the cancer as possible while minimizing cardiotoxicity, and by using guideline-based surveillance and management. I just want to show you just some clips of how detailed our data collection is. So this is a patient, of course there's no identifiers here, from the Adult Survivorship Clinic. As you can see here, there's all kinds of data about what kind of breast cancer they had, what kind of EF they had before they got chemo, what kind of chemo did they get, what was the dosage, the dates, how much radiation, and we have all of these, we collect all of these data from the survivorship point. We also established something that is very unique, first in Georgia, Young Adult Survivorship Clinic, where the children who were treated for cancer at CHOA or any other sites, they come to this Young Adult Survivorship Clinic, and we're trying to establish the program where they are seen the same day, they get the echo the same day, they are seen by me and the Young Adult Survivorship Clinic the same day, because these people are young, like 20, 23, 25. They sometimes are out, they're somewhere else in the country, but they utilize 1 or 2 days to come here, get all their care done in the day. They travel from all over the state to get this done. So we're very, very proud to, we just started this about 6 months ago, and it's going very smoothly so far. We identify some conventional risk factors as well. We have also started research. Actually, that's how this whole program started, with a research protocol. We have a cardio-onc registry that I showed you. We have a novel project, which is testing for subclinical cardiovascular disease. It was funded by Kennedy Foundation. Dr. Riley from School of Nursing was the PI. We just completed the study. We did all the echoes and coronary calcium score biomarkers in patients who have survived lymphoma. We actually developed a protocol for echocardiography. with the help of Sharon and Sandra, who I cannot thank enough. They basically helped us develop a protocol which uses diastole as well as strain measures. We have other resources in this program, which is YMC exercise program, nutrition, psychologists, as well as other physician and specialties. We have, as I just told you, we are starting a cardio-oncology. We started an International Cardio-Oncology Society, and we're developing a fellowship program. The fellows that worked with me are Dr. Brown and Dr. Hung, and one of the students who's also collected some data. This is, if you go to our website, we have written some of the papers. So this is one of some paper that I wrote with Dr. Wenger, and there are a lot of other tips about this. And we also, I think Dr. Hung is not, we also go volunteer for something called Breastival that they hold. This is our booth, which is women and heart disease. And you can see our enthusiastic fellows are there helping educate patients. So I want to come to this case for last 10 minutes. These are real cases, and I want your input on this. So first case, this is a 75-year-old male on Grady Internal Medicine. Dr. Dollar and one of the fellows called me to see what's the right thing to do here, what are some of the options. So this is a 75-year-old male on Grady Internal Medicine with severe multivessel CAD and systolic heart failure with EF of 35 to 40%. He was admitted to the hospital for chest pain. Left heart cath showed 60% ostial left main, 90% prox LAD, 80% sequential left circumflex lesion, and occluded proximal RCA. I swear this is a true case. So bypass was being considered. However, he was found to be anemic, which was found to be secondary to stage 4 metastatic gastric adenocarcinoma. So due to the advanced cancer diagnosis, the plan for surgical revascularization was put on hold. He was readmitted from clinic for transfusion of his anemia. A port was placed, and oncology is considering palliative chemo with 5-FU versus trastuzumab, and Dr. Dollar's team was consulted to help with selecting which agent will be better tolerated from the cardiac standpoint given his advanced CAD and heart failure. The oncology team's concern was worsening heart failure with trastuzumab, as we just saw, and angina MI with 5-FU. So what are your thoughts on this? So should the patient have PCI, bypass, get trastuzumab, 5-FU, hospice, or call a friend? So I called a friend. So I basically wrote an email to the ICOS, the International Cardio-Oncology Society group, and I just presented them the case. And I said, what should we do? I haven't been in this situation before. So I had more than 30 responses from 8 countries about different options. They were going from PCI to bypass to trastuzumab versus 5-FU. But most of the people suggested that we should use 5-FU because the risk of coronary vasospasm is uncommon and reversible. The recommendation was to give 5-FU as a bolus with IV nitro, and that's what it was recommended to the oncology team. That's what the patient got, and actually his EF was unchanged the month later. So that's just a case that shows how important collaboration is. Case 2, and I wish Dr. Langberg was here for this patient, but 68-year-old African-American female with history of heart failure and pulmonary hypertension since 2012 moved to Atlanta to live with her daughter. Left heart cath was normal per outside hospital. Her past medical history was positive for breast cancer. She had surgery. She had anthracycline and trastuzumab in 96, and she had radiation therapy to left chest wall. She came in here for persistent fatigue and dyspnea and exertion. She was diagnosed, as I said, with pulmonary hypertension. She was put on home oxygen or Vashio. She was admitted to Emory with worsening dyspnea. Her exam showed normal blood pressure and heart rate. Her lungs were clear. She had bilateral pitting edema, JVP up to 10 centimeters. Her hemoglobin was 12.6, platelets 122. Her creatinine was 1.42 with BNP of 1753. She had moderate bilateral pleural effusion. This is her EKG. Just let you look at it for a moment here. And this is her echo. As you can see, the LVF is pretty poor. There is a pleural effusion. There's a little bit of pericardial effusion. Left bilateral atria are enlarged. So the question is, what would you do next? So because this actually, when I looked at this echo, I thought of amyloid, and then I was on consult service, and I looked at the EKG, and it's low voltage, even when the left ventricular wall is quite thick, and you can see like it's speckled. So we sent the patient for SPEP UPEP. The SPEP did not show monoclonal protein, but spot UPEP showed 20% of cells with free lambda chain. This is not her MRI, but I sent her for cardiac MRI, which showed diffuse gadolinium enhancement in the subendocardium, as you can see here in the white portion here. Actually, Dr. Book did her biopsy, for endomyocardial biopsy, and you can see this is a Congo red, which is positive for amyloid here. So she was diagnosed with cardiac AL amyloid. Chemotherapy with VCD, Velcade, cyclophosphamide, and dexamethasone was started. Heme was awaiting response to therapy in a month, and they were looking at the free light chain response. The question was, and this is, I don't know the answer to this question, so I would appreciate your input. Should I place an ICD in this lady or not? ICD, raise your hands. Dr. Douglas. So this patient, actually, I had a lot of soul searching to do for this patient, because what happened is that Heme was giving her this chemotherapy, and they were going to await response in a month. But in 1 month, if she was one of the responders, her prognosis would be several years. And if she was not a responder, her prognosis would be few months. So I talked to the patient and his daughter. I spoke to Dr. Kaufman on hematology, and we just deliberated over this issue, and we decided to wait for a month and see if she responded, and that's what the patient wished for. And if she responded, she would want an ICD. If she did not respond, she would not want an ICD. Everybody thinks it's fair enough? So she died of VT in July of 2013, right at the month. She had her free light chain assessed. The next day, she was at home. It was her 40th anniversary, and she died of VT. The results of the free light chain came a day before her death, and she was not responsive. So that was the only good thing that I felt, that I didn't make a mistake. And I called several centers, including Mayo. I remember I was taking echo boards, and I just couldn't study because I thought maybe I should have done something different. And there were no particular ICD guidelines for cardiac amyloid. In retrospect, I think maybe I should have put her on life vest while I was waiting for a month. So I just wanted to present this case to see if anybody else would have done differently. But what I keep thinking, what if she was one of the responders here? Then she could have lived for several years if she didn't have VT.
But that prognosis is based on her, just her ALM, not her pre-birth.
Yeah, I remember calling you too. This is just one of the cases demonstrating that there's no particular there's just a difference in opinion, and there's no standardized guideline. This is a case, actually, this is ongoing, and this is somebody that I just saw Thursday last week. This is 73-year-old male with Hürthle cell thyroid cancer since 2012. Dr. Samadi referred this patient to me. This patient was treated with everolimus, which was stopped due to cardiotoxicity. He had heart failure with EF 20% by echo, diagnosed last year in April. He had left heart cath at that time, which showed LAD 99% at the mid area, and RCA was 100% CTO with collaterals from the left. Cardiac MRI was performed last year to assess viability. The EF was 15%. There was transmural scar in the inferior wall and subendocardial scar in the mid-apical septum and anterior wall. Now thyroid cancer is metastatic. Cardio-Oncology is consulted to evaluate preference for oncology therapy between lenvatinib versus clinical trial drug carfilzomib. So I looked at this and I said, okay. So I had to do some studying. So lenvatinib toxicity is 2/3 of the patients have hypertension. Cardiotoxicity with LV dysfunction is common, and importantly, these patients get arterial thrombosis. And carfilzomib, there's rare cardiotoxicity, but for clinical trial, LVEF has to be normal. So the question is, what is his current EF? Because the last EF we had was last year. Should we revascularize or not? If yes, how would that impact choice of chemo? Should we get ICD? And I would love your thoughts because I really don't know the answer to this question. So the question is, I did the echo the same day. His EF now is 35 to 40%. So the question is, should we revascularize the mid-LAD and CTO in the hopes that it will improve the LVEF and maybe he can tolerate chemo, or should we not? On talking to the oncologist, he said, well, that may help, but if we have a 2 stent, he's going to not want to give the patient this drug because it causes arterial thrombosis. So that's where we are. We haven't made a decision yet. I have to talk to Dr. Samadi and oncologist again, but if you have any thoughts, that will help. Excellent question. So the prognosis is about 18 months to 2 years with treatment. So that's what I'm going to recommend. We're going to have to discuss with him and the family and Dr. Samadi and come up with a plan. So with that, I'll end and I'll take any questions.
Thanks, Susmita. I'll start you with one question. So the guidelines that are coming out, I guess one of the challenges in this field is the level of evidence. So we're used to cardiology, very high level of evidence, multi-center, multiple trials. I suspect a lot of this is small trials and expert opinion. Are there efforts to develop sort of larger sets of data to help guide therapy? I know that a lot of this is individualized, but...
That's an excellent point. You are absolutely correct. Most of the evidence here is either level B or C. And I understand now how these guidelines are made because when we were discussing every month or every 2 weeks on a conference call, every word there was an argument when people said should. Why are you saying should? It should be maybe considered because there's no evidence. So the answer is most of this is level B or C because that's what the best we have. I know several sites in Europe and here other sites are creating large database as we are too, and hopefully in the next few years we should have something that's more definitive.
One thing you seem to place a lot of emphasis throughout this thing on the ejection fraction. How are you calculating the ejection fraction? Because if it's just an observer thing, I would be worried about it.
That is an extremely important point. We are, it's not just 1 or 2 people that are reading the echoes. It's read by everybody. And as you know, ejection fraction, there's no special way to calculate for this patient. But I cannot emphasize enough what you exactly said. Just last week, I saw a 23-year-old. Her chemo was stopped because her EF was read as 45%. And this patient was there crying, and her parents were there. And when I looked at the echo, the EF was absolutely normal. And I got a couple of other colleagues and I said, let's just look at it. And it was a lot of, going back and forth. But the emphasis should be that in patients who are getting chemo, we should really use volumetric analysis, not just subjective visually. And I know Dr. Margolis does that quite a bit because we see a lot of BMT, bone marrow transplant patients in our clinic, in our echo lab, is that you have to really use the volumetric analysis method that we have in the echo criteria and not just go by visual method. And even when Simpson's biplane method is given by by echocardiographers, we have to go back and look at whether those tracing are good or not, because sometimes as you know, there's technically difficult echoes where you can't see the endocardium. And if there's any doubt in the mind, I would really recommend to get another modality such as MUGA or cardiac MR, or with contrast echo would be the easiest thing to go to next level. So that's an extremely important point. Yes, Dr. Lask.
Somebody asked Andy the microphone.
So I have an oncology question. Particularly for breast cancer, and certainly the movement is to treat chemotherapy for earlier stage breast cancer or not. I mean, where are they with finding alternative agents to anthracyclines? And is that, because obviously these drugs have been around for 30 years with this known complication?
What I know about that is anthracyclines are still one of the first line that they use, but there are different ones to adriamycin. There's, to doxorubicin, there's epirubicin and daunorubicin that have lower cardiotoxicity, but I don't know exactly where are they in terms of developing alternative agent. That'll be a good question for our breast colleagues, and I'll definitely make sure to find out. Dr. Smith?
I'm not aware of data of patients with amyloid who have defibrillators, how many have been successfully resuscitated. That might be a good question to review of patients who had ICD implanted for amyloid. How often was it successful? We've seen patients who were tested for defibrillation thresholds in the EP lab who did not recover, went into cardiogenic shock, and that was a patient who did not have known amyloid but was discovered after the fact. Because I suspect that ICD and LifeVest is probably has a much lower efficacy.
That's actually when that case happened, I reviewed some literature, and that's exactly what some of the very limited literature were exactly what you just said. They had a very high defibrillation threshold, and they were not as effective in these patients.
And when you look at the trials of defibrillators that show that you implant 11 to save one life, then factor that into the decision making.
Thank you.
Well, thanks so much, Susmita. I really appreciate it. Great talk.
The preceding program is copyrighted by Emory University.